Good morning, students. Today we are going to learn about fractures of mandibular condyle as a separate entity. We have seen in the last class, we have learned about mandibular angle parasymphysis fractures in particular. The surgical management or basic treatment principles will remain the same. They hold good every day, everywhere, and every other part of the fracture. So you need to remember that the first few chapters are very, very important to understand what is closed reduction, what is open reduction, internal fixation, external fixation. So let's start with mandibular fractures for condyle. And in this chapter, the learning outcomes will be what is the etiology, mechanism of injury of condylar fractures, what are the indications for various treatment methodologies, and how best we can treat the mandibular fractures surgically. So this is going to be the scenario, the learning outcomes. To start with, we will have an introduction, etiology, mechanism of injuries, classifications of condylar fractures, clinical features, investigations, sequelae, treatment, and complications. We'll deal with the end of that, all the mandibular complications in the previous lesson, what we have learned. With the condylar fractures, we'll learn as one last class as complications of mandibular fracture. To start, it is a controversial subject right from the days of evolution of maxillofacial surgery. Even till today, there is lots of debates which are going on, and slowly the debate will be settled. Almost is settled whether to treat the condylar fractures by open method or by closed method. This is the debate. This is what has been the controversial area in maxillofacial surgery. Not that the fracture is controversial, it is the surgical management versus non-surgical management has been in debate for years, decades. Now, as at the end of the chapter, we will learn or understand that this debate for good, it's going to end now. Why condyle is important to learn as a separate entity is because the mechanism of the injury is different. The anatomical structures, the anatomical applied anatomy or the anatomical considerations are different, and the controversy it has created regarding the treatment is different. So that's why we try to learn it separately. There can be predominantly three types of injuries which can occur to the joint proper along with the condyle. You can have a contusion injuries, you can have a dislocation injuries to the TMJ, and you can have fracture. You can have fracture along with dislocation of the condyle also. That's what the classification is going to teach you. Condyle as such, condyle and subcondyle fractures will make up to almost 33% of all mandibular fractures. So you can understand, it got large chunk of incidents. Why? Because it can result in a dysfunction, that is more important. Deformity, as I have said in the last class, any mandible fracture you need to take a OPG, because especially in the children or in the teenagers, growing individuals, it can land up with temporomandibular joint ankylosis. That is deformity. Dysfunction, it can lead to internal derangement, mild subluxation, luxation to internal derangement. Pain, it can be there right from the moment they got injured, long lasting. It will turn out to be a chronic pain. So if you don't treat it, or if it is not managed correctly, the patient can land up with all three of them. A chronic pain which is not subsided, patient is unhappy with that. Dysfunction due to malocclusion or an internal derangement in the joint. A deformity, especially if children, they might land up with post-ankylosis deformities, ankylosis deformities, or if it is an adult also, because of the shortening of the ramus bilaterally or unilateral condyle, they will land up with a certain sort of symmetry, asymmetry. So that is why it is very important on all the aspects to treat and manage them effectively. Condylar fracture is defined as little bit, this is for the PG level. Those who wants to take it down can take it down. It's defined as a fracture starting from the ventral aspect of the condylar neck and the sigmoid notch, extending dorsally and caudally, in extreme cases down to the angle of the mandible. So what are the etiology? Etiology will be the same for most of the maxillofacial trauma, especially in adults, motor vehicle accidents, interpersonal violence, contact sports, accidental falls. In children, falls wherever it is, due at home, at school or at playground, they might sustain the injuries maximum with the falls. The second maximum is while they are cycling, whenever they start learning the cycles. And then in elders, again falls, accidental fall in bathroom, accidental fall while slippery surfaces on a rainy day, assaults and automobile accidents. As I said, the mechanism and pattern is different. Why we should know this? To simplify the diagnosis, how and why it has occurred, and always condyle fractures might be associated with a concomitant or another fracture in the mandible. So you need to look for another fracture in the mandible, if not another fracture in the face. So condyle is an indicator like that. So isolated condyle fractures, very rare to have, but they do occur. But most of the times it gives us sign that you need to look somewhere else also. And 2/3 of all the joint fracture are associated with other fractures of the mandible. That is what is. And they do occur 90% of the time occur due to an indirect trauma. Means trauma is somewhere, but the yielding fracture will be the condyle. This we have discussed in the last classes. What are the influencing factors for the condyle fracture? Most important thing is whether there are teeth present or not. Second thing, occlusion. Third thing, at the time of incident, whether the patient is closed his mouth or opened his mouth at the moment of impact. Direction and the amount of force which is being applied. So these three or four are essential, very important. So as we have learned, we got three types of injuries: kinetic energies, kinetic energy 1, 2 and 3. In kinetic energy 1, the patient is static, he is stable, and the object, in this case the fist, has come violently and hit him. So what will happen in kinetic energy 1? Though the point of impact is the left parasymphysis region, due to the countercoupe, I think I have explained this in the last chapter, countercoupe injury, the yielding of the fracture will be in the opposite side, because the mandible is a U-shaped, bent-shaped, single long bone which is bent in U. The forces usually are transmitted to the weaker areas, the weakest anatomical subsections in mandible being the condylar heads. So it can be transmitted to the same side, it can be transmitted to the opposite side, but whenever there is a direction which is coming from opposite side, ideally or most commonly it will be the contacupa injury, or the opposite side region condyle is going to fracture. So this is from kinetic energy 1, where the patient is static, object is fixed here, it is in motion. In kinetic energy 2, the object is stable, here the object is ground, the patient is in movement, the patient has fallen on the ground directly over the chin. This is only usually called parade ground fracture or guardsman fracture. When the army people, constantly for a long period of time they are doing parade, and due to hypoglycemia or syncope, guards who are on guard duty at the sentry duty for a long hours standing outside a police station or a army barracks, so they are going to get that reeling, and then when they fall flat on the chin or the ground, this is kinetic energy 2. This will lead to a symphysis fracture exactly in the midline when you fall over the chin, and bilateral condyle fracture. This is also common in children. When the children fall flat on the ground, they will have a condyle symphysis fracture, and bilateral condyle fracture. Here it is the point of impact where the fracture has occurred, the point of impact being the parasymphysis region, and opposite condyle has fractured. Here the point of impact is exactly at the chin, so the anatomical suture line, symphysis suture line, will lead to the fracture, and the forces are transmitted along the body angle and to the condyle. Condylar neck being the weaker, you will have the fracture there. In children, especially in younger children, the condylar head is more hyalinized, it is more cartilaginous, so you tend to have a mushroom type of a shattering of the condylar head rather than a condylar neck being fractured. Neck usually adults will have it. Now in kinetic energy 3, wherein you have both kinetic energy 1 and 2, that means the patient is in movement and the vehicle or the object is also in movement. So this is like a car dashboard where the car is also moving, the patient being the driver, the patient also has in motion due to whiplash injury, he is moving there and he's hit the dashboard. So you will end up with bilateral parasymphysis fractures and bilateral condyle. This is the possible 3 mechanisms of condylar fracture and the biomechanics involved there. How they have classified these injuries is the simple classification is 1 unilateral or bilateral, 2 intracapsular or extracapsular. The TMJ capsule is going to cover the head of the condyle. So whatever head fractures will come as intracapsular, neck and the subcondylar fractures will come as extracapsular. Another classification, simple compound comminuted. You can have a simple fracture. Compound getting exposed to the air is very rare in condyle. I haven't seen till now, except for a one panfacial injury where there was a complete loss of soft tissue. Otherwise, till now I haven't seen a compound fracture where it is exposed either intraorally or extraorally. You will have the condyle fractures as most commonly simple fracture, which means that it is not exposed to the exterior. Comminuted, you can have multiple fracture. As I said, in children you can have shattering of the condylar head, you can have multiple comminution. Lindahl has given a classification in 1977. Based on three components, it will have three components. Level of the fracture, so level of the fracture being condylar head fractures, the ones which are denoted in the blue area, intracapsule, till here the capsule is going to cover that. The level of the fracture, right? Condylar head fracture, then condylar neck fractures, exactly the neck of the condyle between condyle and the ramus unit, and subcondylar fracture, right from the sigmoid notch, any fracture which is traversing posteriorly towards the posterior border of the mandible, they are sigmoid subcondylar fractures. Subcondyle, condylar neck, and condylar head fractures. These are the level of fractures. And one anatomical important aspect you need to know is that the lateral pterygoid muscle is going to attach into the condylar head region. It is going to divide into superior head and inferior head. The superior head will get merged with the articulating disc. The inferior head gets attached to the pterygoid fovea. So why this is, why I'm emphasizing or telling this is that the displacement of the condylar fracture will depend on this. Because of the attachment of the lateral pterygoid muscle, most of the times the condylar fractures are displaced anteriorly and medially. Because the muscle origin is medial to the condylar head, so it is origin is anteromedial. So towards the origin of the muscle or towards the action of the muscle, usually the bone fragment will get displaced. So most likely displacement direction is anteromedial direction for that reason. The second one, the relationship of the condylar head in relation to the proximal segment to distal segment. Distal segment is the rest of the ramus or the condyle part. In relation to that, he is going to divide that. So the first we have seen condylar head, neck and subcondyle. Whether the fracture is displaced or undisplaced, that is one important fact. Whether the fracture has occurred, the fracture is there, but both the components, this is the proximal segment, that is the distal segment. Proximal, most towards the TMJ, distal, away from the TMJ. So the proximal and distal segments are together in contact, they are not displaced. They are fractured in contact, but there is a slight deviation. They are deviated. Displaced medially, displaced laterally. So this is L indicates lateral, displaced M indicates. As we have noticed that most of the times it is the attachment here, exactly the pointer where I kept, that is where the lateral pterygoid muscle is going to attach. So anteromedial direction is the most common displacement, medial displacement, lateral displacement, and then anteroposterior displacement. So that is one. And then there is absolutely no contact between both fragments. This is another. The third one is in relation to the glenoid fossa. The condylar head fractured end is undisplaced. The condylar head is displaced. The condylar head is out of the glenoid fossa, dislocated. So this is how he has classified into three subsections. That's a picture just to visualize so that you can understand better. McLennan has given a previous classification. Lindahl has modified that. So you whenever there is a condyle fracture question, classify Lindahl's classification, most widely accepted classification. Later we have, till recently 2006, there is a Lakota classification. Almost 10 to 14 classifications are there. What is expected from an undergraduate is McLennan's classification. And we have further condylar head subclassifications, type A, B and C by Neff, and then there is another classification called modified Neff's classification. These are all next level, PG level, and then entrance exam questions. For undergraduate, I think Lindahl's classification holds good better. So in condylar head fractures, you can have simple fracture, you can have comminuted fracture, or you can have a mushroom type fracture, which is commonly seen in children. Another condition, entrance exam question, caput protrusio glenoidalis, a condyle which has protruded into the glenoid fossa. Due to the impact on the chin, the condyles, instead of yielding at the neck, the force is transmitted to the articulating disc, articulating fossa, glenoid fossa. The fossa's floor or roof of the fossa is formed by the petrous part of the temporal bone, and then this being very thin there, the force being more, the condyle, entire condyle, either unilaterally or bilaterally, can penetrate into the middle cranial fossa. These things have occurred, and it is being reported. Almost more than 24 to 26 cases have been reported as of now in the literature. So there is a condition called caput protrusio glenoidalis, where the condyle has protruded into the glenoid fossa. When the condyle goes into the glenoid fossa, what are the neurological or ENT signs you get to notice? There will be CSF otorrhea through the external artery meatus. You see CSF leak, paralysis of facial nerve, because petrous part of the temporal bone region only, the vestibulocochlear apparatus will be there, so that you will have a paralysis of facial nerve. Hemorrhage from the middle meningeal artery, just over or the middle cranial fossa. You will see that underneath the cerebellum, you will see the middle meningeal artery. So that artery is going to bleed within the cranial vault. Dural tears, subdural or epidural hematoma, altered consciousness, pupillary dilation, and nausea and vomiting due to head injury. These are all indications of head injury. Intracranial bleeding can occur, whether it is subdural or epidural hematoma, or you can have a middle meningeal artery bleeding, which can be evident at times over the mastoid process that is called battle sign. It indicates a fracture of base of the cranium, but even in this also, due to hemorrhage from the middle meningeal artery, all these features can be seen. What will be the clinical features, what you can notice in this kind of fractures? On extraoral inspection, there may be or may not be facial asymmetry. Both can be seen. Sometimes undisplaced fractures will never produce an asymmetry, but if there is associated injuries, soft tissue injuries, or swelling over the TMJ, then definitely there will be facial asymmetry. Facial asymmetry, first thing on inspection. Second thing, an evidence of trauma, either because of direct or indirect contact or non-contact, whatever might be there, you need to see evidence of trauma which has occurred over the chin or the lower border of the mandible or any other facial lacerations. Bleeding from external acoustic meatus or external artery canal. This usually occurs not because something damage has occurred inside the ear, because of the violent force which is transmitted into the glenoid fossa, and external acoustic meatus just lying very next to the glenoid fossa. That force get transmitted into the middle ear, and then the tympanic membrane usually gets injured. We can't say that it is a big tear, but that violent force, the movements or vibrations can cause little bit of tear there, and then or even the inner lining, the soft tissue lining inside the skin can also get tethered there, and then you will have the bleeding. If you see a CSF otorrhea, a clear fluid apart from your blood, then it indicates that there is a base of the cranium fracture or a caput protrusio glenoidalis condition where the condyle has gone inside. Then swelling over the TMJ, obviously whenever there is huge bleeding, hemarthrosis to a fracture which has got significant amount of bleeding, there will be a swelling. but most of the times due to the presence of masseter, uh, this is contained in, especially in subcondylar fractures and the ramus fractures. Underneath the masseter they will swell, so you can have swelling over the TMJ region. Deviation of mandible midline at rest or on mouth opening. If it is a unilateral condyle fracture, you will have deviation. You ask the patient to open the mouth, you can have deviation. You can see the patient having a open bite also on inspection. On palpation, tenderness with crepitation over the TMJ region, and you ask the patient to open the mouth, protrude the mouth, definitely not possible in a fracture condyle. And definitely the patient will be under severe intense pain. On clinical examination intraorally, you'll find there is a malocclusion. You'll find that reduced interincisal opening, patient cannot wide open. There will be premature contacts, especially with unilateral condyle fractures. You can have anterior open bite with bilateral condyle fractures. You can have posterior gagging of occlusion. That is also due to decreased loss of ramal height bilaterally, can produce bilateral posterior gagging, or if it is unilateral fracture, it will produce unilateral posterior gagging. So what are the clinical features in a unilateral condyle fracture? Deviation of the midline. This is the midline between two central incisors. This is midline between two central incisors here. So midline shift, lateral movements limited, ipsilateral, same side, ipsilateral, premature contact, opposite side, open bite. Ipsilateral, same side, contact, midline shift to the same side, opposite side, open bite. These are all the classical features of condylar fracture. The midline is shifted, ipsilateral, premature contact, opposite side, open bite. This is unilateral condylar fracture features. Bilateral posterior premature contact. There you have a premature contact, you have a premature contact, and open bite, complete anterior open bite. The midline usually will not be deviated. So see that central incisor. There is a parasymphysis fracture here. That is why you have seen a step deformity. There is a midline symphysis fracture. That's the classical feature, bilateral posterior gagging or premature contact with anterior open bite with a symphysis fracture. And because it is bilateral fracture, the patient will not be able to either wide open or cause lateral excursion and protrusion and retrusion movements. So all these things are not possible, and because of the bilateral condyle fracture and shortening of the ramus, the entire mandible appears a little bit posteriorly placed, so it will appear more like a retrognathia. So when I said there is decrease in height of the posterior condylar height, this is what I mean. Usually if you measure from the condylar height to the angle, this is the height of the ramus. When there is fracture which has occurred and the condyle is displaced, there will be contraction. Means there will be loss of the posterior height. Because of the loss of the posterior height, the midline is being shifted. The entire mandible is being pulled to the same side, ipsilateral side. So there will be decreased in the ramus height on the same side, ipsilateral side. Midline is shifted to the same side. There will be premature contact because of the contraction, premature contact of the teeth, and then opposite side open bite. These are all the one diagram which depicts all the clinical features of unilateral condyle fracture. So this is bilateral condyle fracture where there is contraction, bilateral, contraction bilaterally, and because of the contraction both sides, you tend to get both sides premature contact. Because of the both sides posterior premature contact or gagging, you will have anterior open bite without any shift in the midline. So midline stays at the midline. Bilateral contraction of the height of the ramal condylar component produces premature gagging or premature contact in the posterior teeth, and then there will be anterior open bite. There is another condition apart from fracture, something called hemarthrosis. There won't be a fracture. It usually mimics a unilateral condyle fracture, but the entire joint is filled with the blood. That is why it is hemarthrosis. Here you will not see contracture. It is distraction. There it was contraction due to loss of the vertical height of the ramus. Here the blood within the joint will push the condyle out, so there will be distraction. There will be posterior open bite on the injured side, so midline is shifted to the opposite side. Then you will see a premature contact in the opposite side. Suddenly you might notice that the injury is there on the right side, but all the features of ipsilateral condyle fracture on the left side will appear. And then you search, there won't be any fracture noted in the left side. That is why you need to know this condition also, because just being presence of a midline shift and a contact, premature contact, and then there is an open bite on opposite side doesn't mean that there is a fracture there on the left side. It is in fact features which mimic due to hemarthrosis, exactly opposite signs and symptoms seen in the opposite side. So don't get confused with that. So usually in examination, the examiner will question this: what are the features of unilateral condyle, what are the features of bilateral condyle, and then they will ask you, these are the symptoms which are seen, what is the condition. So usually this is hemarthrosis. You can have a fracture, you can have a joint effusion, that is hemarthrosis. At the same time, you can have another injury due to trauma, that is condylar dislocation, where the condyle has come out of the glenoid fossa. Either it can be unilateral or it can be bilateral. This condition can occur without fracture, can occur with fracture. When it occurs without fracture, it is called acute dislocation due to trauma. Acute unilateral dislocation, acute bilateral dislocation. The clinical features will be open bite on the affected side. When the condyle is dislocated on right condyle, right side occlusion, there will be open bite, deviation of the mandible to the opposite side. So these are the clinical features. If it is a bilateral dislocation, complete open bite, there won't be any gagging, posterior gagging. There won't be anterior open bite. It will be a complete open bite from molar to molar. No teeth will be in contact. Patient will highly impossible that he will be able to occlude that. And then there will be prognathism. In bilateral condyle fracture, you will have retrognathism. In bilateral condyle dislocation, you will have pseudoprognatism. So these are one picture which is depicting all the four conditions: a dislocation, a hemarthrosis, dislocation, unilateral condyle, and bilateral condyle. Just go through the picture again and again to understand once for all permanently. So whenever somebody is going to ask you what are the clinical features in the long question, you need to write all this. Not just pain, fever, nausea, vomiting, diarrhea. These are, so many students commonly write these as clinical features for every possible condition in the world. So that is how you get more marks or less marks. Even though you have attempted, you have written, not writing specific points will not give you enough marks. It is not the number of pages you have filled, it is the content in the paper which will give you good marks. What are the investigations which are commonly employed? OPG by far is the best possible investigation, radiological investigation for condyle fracture. You can see everything in the condyle. Only thing that whether it is medially displaced or laterally displaced, the condylar stem We cannot see it on OPG, so we require a third dimension. Usually it is a scalp-A anterior-posterior, scalp-A posterior-anterior view will give you whether the condyle has displaced anteriorly, laterally or medially. And you get a CT scan, that is the best possible thing. You get a 3D CT scan, even best. We can notice where exactly the condyle is present. So these are all the X-rays, AP views, reverse stones view, OPG, and this is what I was talking about. You need a CT scan to exactly see how the condyle is displaced. The condyle head is more towards the medial side, the stump is more towards the, these are sometimes very difficult to reduce. You need lot of skill, surgical skill. As I said, there is an indirect injury, there is a fracture here in the parasymphysis region, there is a fracture in the subcondylar region. And you can notice laterally displaced. This is the condylar region on a skull PA. Laterally displaced, just like what we have seen in Lindahl's classification. If it is present this side, it is called medial displacement. If it is present that side, it is called lateral displacement. In a CT scan again, you can see that medial displaced. There we have seen the condylar segment displacing laterally. Another image where I've kept it that there is a medial displacement of the condyle. This is the CT scan. This is how the fracture looks like, and this is post surgery near anatomical alignment, and then they have placed the plate. So these are the best possible investigation. Whether to do the surgical management or not is the most debated question. So go in for open reduction versus closed reduction, open reduction surgically or not, non-surgical closed management is the best. So it is the most debated thing in maxillofacial surgery, as I've said. Why? Because the anatomical region being too open, previously the surgeons used to get scared of facial paralysis. Just overlying the TMJ, you have parotid gland. Within the parotid gland, the facial nerve is going to get divided into 5 terminal branches, upper division 3 branches and lower division 2 branches. We'll discuss that. And this is the anatomical significance. 1, the parotid. 2, the facial nerve. 3, the retromandibular vein. 4, the maxillary artery. The maxillary artery lies medial to the condyle. So once if it is get damaged and the small space, you cannot control the hemorrhage from the maxillary artery. To some extent we can control the retromandibular vein. So because of this huge vascular structures and the important facial nerve, you do the surgery, the patient lands up with a facial nerve paralysis, and that is why even the patient used to not give consent. The surgeon was not very confident to go through the facial nerve and approach the condyle, the TMJ, which is present very close, very medially there. These things have affected these anatomical landmarks, and the following succeeding complications have made opening much difficult, and the clinical expertise given. Very few people in those olden days used to get experienced hands with condyle. Nowadays we open most possibly, except condylar head and very badly displaced condyles, we open all the condyles and try to fix them, and we have done almost 7 to 8 theses in condyle. So with the clinical advancement of the surgical techniques, clinical approaches, training imparted to the next generation, nowadays everybody is confident in opening. So what are the goals of the treatment of the condylar fracture is that the patient should be relieved from pain. You need to get a stable occlusion post-treatment, restoration of the mouth opening to the nearest possible mouth opening. If imagine 40 millimeters to 45 millimeters is the normal range, at least you should get somewhere about 35. A full range of mandibular movements, all excursion, protrusion, retrusion, and minimize deviation while opening the mouth. Post-operatively, whether it is closed or open, while mouth opening, patient should not have significant deviation. This will alter his psyche. Somebody noticing you, and then while you speak or open, if the lower jaw is getting deviated again and again, so imagine how much it is going to affect the patient psyche. And avoid growth disturbances, especially in children. Condyle being the primary site, important site of growth for forward and downward displacement, and prevention of ankylosis. I think I have discussed again and again this point. So if at all you have to open, there have been indications which have been proposed by Zaid and Kent and Rave. They have given these indications, relative indications and absolute indications. And what are the reasons for open reduction and fixation? To support open reduction, when to open, you need not place the patient in IMF for 4 weeks, 6 weeks. You can achieve a primary healing and avoid shortening of the ramus. In close reduction, since we don't reduce the condyle fracture, we allow it to heal by secondary intention. There can be always some amount of foreshortening, because of which you can have a mild deviation, because of which you can have a internal derangement, because of which you can have a trauma-related arthritis or a period of time, because the condyle is not placed exactly in its near anatomical position. So what are those indications? Absolute indications for opening the condyle is limitation of function secondary to the following: a fracture into the middle cranial fossa. The condyle has protruded into the middle cranial fossa, you have to remove it. A foreign body within the joint capsule. Due to trauma or any injury, something has penetrated into the joint capsule, you have to remove it. A lateral extracapsular dislocation of the condyle, because once it is laterally dislocated, that stump is going to stand there, it is going to cause disfigurement, and as well that it is highly impossible by closed reduction that it gets manipulated. So a laterally displaced condyle, very badly laterally displaced condyle, a foreign body within the joint capsule, and the condyle which has gone into the middle cranial fossa. These are all absolute indication. Mechanical obstruction for further function. No, you feel that we'll always place arch bar for every possible patient of the condyle fracture, and then assess if the occlusion is being achieved either by traction or either by MMF. If the occlusion is not achieved due to fracture, or either it is unilaterally or bilaterally, if there is an obstruction for the function of the TMJ, you have to open that. So that is one important thing. An open injury, very rarely it can occur. An open injury, a penetrating, avulsing or laterizing injury into the TMJ. Though it is very rare, that is one indication. Relative indications are bilateral condyle fractures in an edentulous patients where splints cannot be placed due to ridge atrophy. So that is one indication. The second one, bilateral fractures associated with comminuted midface fractures. You have multiple panfacial injury. That is one word. Panfacial injury, bilateral fracture associated with panfacial injuries. It's a relative indication. And situations where IMF cannot be placed, especially patients with seizures, epileptics. You cannot place them in IMF whenever they are having a seizure. You can have a tongue fall back, you can have tongue getting obstructed or choking. So that is life is more important than having a fracture. A psychiatric disorder patient who cannot manage this, they cannot give you full cooperation to you, they cannot be in compliance with your treatment, So there you have to do a open reduction, and severe mental retardation due to any problems, either a genetical problem or other problem. A mentally retarded, a psychiatric patient, an epileptic patient, these are all relative contraindications to go for a open reduction. So with this we'll end today's class. It is 45 minutes, and next class we are going to learn about what are the treatment modalities. Thank you.